There are several tests that are done preoperatively to determine pathology and treatment. Pulmonary function tests measure the lungs' function. Tidal volume is the amount of air exhaled during normal respiration. Vital capacity is the total volume of air exhaled after maximum inspiration. The total lung capacity is the total amount of air in the lungs when fully inflated. Laboratory tests or blood work include CBC, which is a complete blood count, and ABGs, which stands for arterial blood gases. These tests measure things like pH and CO2 in the arterial or oxygenated blood. Imaging studies such as X-ray, CAT scan, or MRI are used to find tumors, space, or fluid in the thoracic cavity. A thoracentesis might also be done. A thoracentesis is done to remove fluid and air from the chest. Normally, a very little amount of fluid is in the space to lubricate the lining between the lungs and the chest wall. This fluid is collected for testing during a thoracentesis. Instrumentation for thoracic surgery will include general instruments, chest wall instruments, lung instruments, bronchus clamps, surgical stapling devices, and vascular clamps. The next few slides will show some of the common instruments used for thoracic and pulmonary procedures. The Davidson scapular retractor is used to separate the shoulder muscles. The Bethune rib shears are used to cut the ribs. The Adson or other rongeurs are used to trim the ribs. And the rib contractor is a closing retractor used to approximate the ribs. The Matson, Alexander, and Doyens are all thoracic elevators which are used to free periosteum from the ribs. The Duval clamp and the Allison retractor are also commonly used on the lungs. A bronchoscopy is an endoscopic examination of the trachea and bronchi. It can be rigid or flexible. A bronchoscopy is performed to control hemorrhage, obtain washings with the use of a Lucan trap and sterile saline, laser ablation, assessing traumatic injuries, retrieving foreign bodies, and to make diagnosis by taking biopsies from the lower respiratory tract. A rigid bronchoscopy is the insertion of a rigid fiber optic telescope into the trachea and bronchi. It is not considered a sterile procedure. This type of bronchoscope is generally only used for the removal of large tissue or foreign bodies in the brachial tree and is usually done with the patient in the supine position. A flexible bronchoscopy is the insertion of a flexible scope and is also not considered a sterile procedure. It is usually done with the patient in the sitting position for examination or to obtain biopsies in the lower respiratory tract.
Your doctor may perform a bronchoscopy to look for and diagnose problems inside your lungs. Your nose and mouth are points of entry for air to move in and out of your lungs through your trachea or windpipe and bronchial tubes. With each breath, your lungs inhale oxygen and exhale carbon dioxide. This exchange of gases is the way your body gets oxygen into your blood. A bronchoscopy may be done to look for and possibly retrieve a foreign object that may have been inhaled instead of swallowed, investigate a persistent cough or a cough producing blood, obtain a mucus, tissue, or liquid sample from inside your lungs, or evaluate an abnormal chest X-ray or CT scan. Before your procedure, you will receive medication to help you relax and minimize coughing. An intravenous line will be inserted for additional medications. Your heart and blood pressure will be monitored, and you will be given extra oxygen during the procedure. You will be given either a local anesthetic to numb your throat or general anesthesia. During the procedure, your doctor will slowly thread a bronchoscope through your nose or mouth, down your throat, past your vocal cords, through your trachea, and into your bronchial tubes. He or she will carefully examine the lining of your airways and may take samples for laboratory examination or remove a foreign object.
A medionoscopy is a sterile procedure, usually done with the patient in the supine position for the endoscopic examination of the mediastinum through an incision in the suprasternal notch. This is performed to examine the trachea, bronchial tree, aortic arch, and the lymph nodes. Thymus and lymph node biopsies are performed to establish a diagnosis and detect stages of cancer. The position for most patients having thoracic surgery is in the lateral position. Oftentimes, an axillary roll will be used in the axilla. Slight variations of the lateral position can be used depending on what incisions are to be made. The usual prep parameters are that the prep extends from the lower neck, chest, arms, shoulder, and axilla to the iliac crest, and to the tabletop on both sides. Oftentimes, a steri-drape or ioban drape will be used. Video-assisted thoracic surgery, otherwise known as VATS, V-A-T-S, is a minimally invasive surgery of the thoracic cavity. It is also known as a thoracoscopy. These procedures are similar to general and GYN laparoscopic cases in that a 10 or 5 millimeter, 0 and 30 degree scope are used, light source, and camera. However, CO2 is usually not instilled into the thoracic cavity. The same safety precautions must be maintained in all endoscopic procedures. Trocar placement depends on what procedure is being performed. VATS is performed with the patient in the lateral position with the operative side up. A double lumen ETT, or endotracheal tube, is often used by anesthesia so the operative lung can be collapsed while anesthesia and oxygen are administered to the opposite lung during general anesthesia. VATS is indicated to diagnose or stage lung cancer, diagnose and treat fluid around the lung, Diagnose and treat fluid around the heart. Diagnose and treat mediastinal tumors, tumors in the area between the lungs. Treat blebs or small sacs of air on the lungs, which can lead to a collapsed lung. Treat lung cancer in patients who cannot tolerate open surgery and reduce lung volume in emphysemic patients.